I would like to invite Dr. Rahul Pandit o- on the stage. He is a chair critical care at Sir H.N. Reliance Foundation Hospital, Mumbai. He is also visiting consultant at Barthus Hospital and Wagga Wagga Hospital, Australia. He is member National Task Force appointed by Supreme Court, and also he is a teacher of College of Critical Care at Australia and also recognized teacher at ISCCM India. Over to Dr. Rahul Pandit sir on obstructive emergencies in ICU and overstimulating disease in obstetric care.
Thank you very much, Association of Physicians of Rajkot, Mayank Bhai, Gunjan Bhai, and my ICU colleagues here for this wonderful opportunity. I am standing between you and lunch, so I will try and finish before the school bell rings. We will try and do that. Can I have my slides, please? Thank you. So, I'm going to talk about two things. I'm going to talk about obstetric emergencies and I'm going to talk about ovarian hyperstimulation syndrome, both. Now, if you look at this, this is 52 weeks and we've got 52 obstetric emergencies in the ICU. And the way I categorize them is you have a pregnancy-related obstetric disorders, which happen because the lady becomes pregnant and you have problems because of which. And majority of them, of course, come up with bleeding disorders, obstetric hysterectomies, and you have sometimes DIC because of that. And of course, there are some medical disorders which only manifest during pregnancy and the lady is completely unaware of it. Or you have patients who know that they have a medical problem and they take a due risk, due diligence, and come up with a pregnancy plan. And sometimes they land up in ICU either prophylactically or they land up in ICU on an emergency basis. If you look at my data here, the ovarian hyperstimulation syndrome, we only had one case in the last 1 year. So thankfully, it's not a big problem for us in ICU. But again, physicians, I think a lot of physicians see it as an OPD basis in the wards. Thankfully, critically ill patients are not that much who come up with ovarian hyperstimulation syndrome. But we see a spectrum of these problems, and I'm just going to go through a little bit of physiology of what creates this problem in pregnant women, and then we'll come to the ovarian hyperstimulation syndrome. So pregnancy, I like to call it as a stress test. It is a stress test for the mother. What a mother undergoes, especially during the labor, if it's a normal delivery which the mother is undergoing, the labor is almost as equivalent to a stress test, perhaps even more than a stress test that a lady would endure. And to go through that successfully and have no problems, it probably tells you that at least the cardiovascular system is reasonably good and healthy. There is no problem. Because if it is not, trust me, there will be some manifestation. And you will see that during the labor. Absolutely, as the term comes where the baby needs to be delivered, you will see some manifestations of that happening clinically. Now, I speak in a lot of obstetric conferences, and I'm very delighted that you actually asked me to speak on obstetric emergencies in the ICU as well as ovarian hyperstimulation syndrome. And I tell the obstetricians that you are in a unique position that almost all of you have the PCPNDT license because you have an echocardiogram, you have ultrasound probe with you. And the same curvilinear probe, I'm not even talking about a cardiac probe, the same curvilinear probe which you use to do abdominal ultrasound of the mother, if you could just put it at one point, which is the apex, and try and understand whether the heart is contracting well or not, you will save a lot of your stress going for the obstetrician as well as the anesthetist. And you will actually refer these patients early. And it's not uncommon that I see such hearts coming to me in the ICU with patients who have just been delivered or who are about to be delivered, and they find out that this patient went into pulmonary edema. And it's all about a significant number of them. Because we are a tertiary care, we get a lot of these referrals. I'm not saying that the institute, every institute will get it. A tertiary care with a special interest in obstetrics, we get a lot of these patients referred to us who during the delivery or just before delivery have an incident which sort of leads to an echo, and they find out that this is what is happening with them. This is another patient, completely normal but very, very thin-built lady who had a normal vaginal delivery attempted by the obstetrician. and went into profound cardiac failure, came to us. We could not find the LV was actually hyperdynamic. When we did a CT scan, we found a big coarctation of the aorta there. And that's where the problem was. The LV was strong, was trying to beat against that coarctation of the aorta. Thankfully, it had not failed and she didn't go into a cardiac arrest. But otherwise, I think we were almost close to a point where she would have gone into a cardiac arrest. These cardiovascular changes put a lot of metabolic demand on the mother when she becomes pregnant. There is an increase in the blood volume. There is a RBC mass which changes. Obviously, the viscosity changes as well. And if you see that when the cardiac output increases, they usually have a deterioration in their symptoms if they are not there. And the bigger picture is basically because of the increase in the oxygen demand, which leads to an increase in the cardiac output. I'm going to skip those couple of slides so that we come up to the bigger picture here. Now, if you have a pre-existing problem, it may not be unreasonable to think that you may have to undergo some procedures to make sure that the mother goes through the pregnancy very safely. Especially valvular heart disease, I think, can be treated significantly easier for the mother to sort of go through the pregnancy without any problems. And cardiologists are quite helpful in their intervention procedures nowadays. So you don't actually have to go for a surgical approach. Most cardiologists will be able to do an intervention and help them have at least a valve dilated, or if not, I think a termination of a pregnancy should be something which one should be considering it. Now I'm going to come to the other part. We saw the heart problems, lung problems. So respiratory system undergoes a significant quantum change as well. And what happens is there's an increase in the oxygen demand, and there's an increase in the oxygen consumption because of which. And that leads to a little hyperventilation where the CO2 goes down. As the CO2 goes down, you would normally see that your bicarbonate would increase, but here it doesn't happen that way. Sort of the bicarbonate goes slowly down as well. So the compensatory mechanism in the lady becomes a problem, and they very quickly go into a respiratory failure as well. Plus, there is a decrease in the FRC, which is the primary reason why the respiratory compensation of bicarbonate does not happen adequately. And then, if you have to intubate this patient, even if there's any anesthetist here attending today, or if you have seen physicians who are dealing with pregnancy or pregnancy-related problems, if you have to intubate a lady who is pregnant, who is at term, they desaturate so rapidly that you actually don't have a lot of time to intubate them safely, as you would do for a non-pregnant person. The same lady, if she was not pregnant, she would have taken apnea of a couple of minutes very easily, and you would have enough time to intubate. Here, the intubation becomes difficult, plus the apnea is not tolerated well. So rather than giving you these 4 lines, I would just give you this picture. This is what the tank looks like. In a non-pregnant lady, you have the big cylinder, which sort of talks about the functional residual capacity being that big. And as the pregnancy progresses, towards the 9th month, 8th month, your tank reserve goes really down. And that's why your acidosis, your mild alkalosis, respiratory alkalosis with metabolic compensation, which tries to sort of have a buffer of the CO2 going up. So if you look at the arterial blood gas, you can see that in a non-pregnant lady, a normal person's CO2 would be 40, whereas a pregnant lady's CO2 comes to near about 30 millimeters of mercury. The oxygen remains more or less stable. pH becomes slightly alkalotic pH, but the bicarbonate, which would have normally gone up, actually drops down. So their compensatory mechanisms are completely challenged here. I've got 2 short cases, very nice and crisp. I don't have a lot to talk about in terms of what we did, is what I'm just highlighting in few slides there. So this is the patient, a 33-year-old lady, came to us post-delivery, had a history of diabetes mellitus as well as preeclampsia. And she started having symptoms of respiratory distress around few weeks before she presented to us. And by the time she presented to us, this was the CT scan on the admission, a very bad viral pneumonia. And this is all post-COVID I'm talking about. These are not COVID pictures. This is bad viral pneumonia. The ABG showed profound hypoxia on 100% FiO2, PaO2 of 82. Those of you who understand the Berlin criteria, you are in severe ARDS already. But along with that, the PCO2 was also in the 80s. So you had a profound respiratory failure, both type 1 and type 2 here, and you had to have something to intervene it. We, of course, intubated this lady, and lo and behold, nothing could be done in terms of trying to improve her oxygenation or clear her CO2. Now, what we did was, we did two things, and both the cases we did the similar things. We did a emergency cesarean section in the ICU at the bedside. So that's the first thing I did. The first thing we did, because normally what I would want to do for these patients, I would want to prone them and try and improve their oxygenation, or I would like to go ahead on ECMO. So for either of that, because she was near term, we did an emergency cesarean section at the bedside, and then after a day of that, we put her on ECMO. Despite proning her, it did not improve. On the day of that, we pruned her, and then we could successfully explant the ECMO on day 7, and post-explantation, the X-ray was a bit better. She was fine. She went home, no problems at all. Again, a 38-year-old lady. She had a twin pregnancy, 28 weeks gestation. She also had a complete placenta previa, and she came to us again looking in a very bad shape, transferred from another hospital. Again, a referral center. We keep on taking patients who are already into the phase where complications have happened for a few days, and they get referred to us. So this patient again had very bad arterial blood gas. We progressed on to the similar sort of a thing what we did for the first lady as well. We intubated, we did a cesarean section in the ICU. We prone ventilated her for 5 days. The family was not very keen on putting them on ECMO. We sort of insisted that we should put on ECMO. Ultimately, we did have a severe respiratory distress despite going in for around 2 weeks. And then we had to put her on ECMO. And the ECMO ultimately led to a lung transplant, and this lady survived the lung transplant. I think she still follows up with our lung physicians, doesn't come to us, of course, in ICU, but she is doing well. So these are disasters waiting for happening, and low lung volumes, low FRC, obesity, low threshold for apnea, hypoxia, worse cardiac output. These are some of the things which complicate the pregnancy so much. And why do we need to know this? Because there are special considerations. And I realized this during COVID. During COVID, I was leading the Maharashtra government task force. So I used to get referrals about all these complex patients from across the city, sometimes across the country as well. And I must have advised at least 5 or 6 obstetric colleagues to please deliver the patient. Do not worry about the baby, worry about the mother. And I want to put this message loud and clear here. Your primary responsibility is towards the mother. The secondary responsibility is towards the baby. If you try and save the mother, there's a good chance that the baby will survive. If you try and just look after the baby's survival, there's a very, very, very big chance that you may lose the mother. So it's the other way around. You have to look after the mother first, try and save the mother's life, the baby may survive. If the mother's life is not survived, I think the baby, no matter what, you will not have a very good time with the baby. So remember, you need to think about cardiorespiratory problems. Now, coming to my second topic, ovarian hyperstimulation syndrome. I would like to cover up with these 6 or 7 succinct points: incident, classification, pathophysiology features, prevention and management. Now, prevention really I have skipped out. I am not an obstetrician. I can't prevent them. They come to me with an ovarian hyperstimulation syndrome. So we had one around 2 weeks ago in our ICU briefly for half a day. More of a panic call by the obstetrician to try and admit the patient, but she was fine. So I have not put her up as a case here, but I will go through the pathophysiology and stuff. So it's an iatrogenic problem. We create something to induce assisted reproduction, and we give them hormones. We, in the sense I'm talking about all us as doctors, and it leads to a hyperstimulation of the ovaries, which then leads to a large cystic enlargement of the ovaries, leading to fluid shifts in the body, and you have a lot of third spacing of the fluids. And fortunately, it can only be life-threatening in just under 2% of the population. So it's not really high, and your mortality from that is around 1 in half a million. So around one patient who gets, around 500,000 patients who get ovarian hyperstimulation syndrome, you lose one of them. But every life is precious. I think that's what the message should be, that we should not try to lose anybody with an ovarian hyperstimulation syndrome. Clinically significant OHSS happens only in around 2 to 3 people. 2 to 3% of the people. So you may get OHSS very common in obstetric, in a assisted reproductive obstetric practice, but coming to you would only be those 2 or 3% of the people who may want to come and help, you might want to help them out. The Royal College of Obstetricians and Gynecologists classified this into a very simple way. So when I read through the classification, because when they come to us, they are all severe, but I had to know what is mild, moderate and severe. There are at least 8 or 9 classifications which have happened since 60s onwards. So there are at least 8 or 9 different classifications. I found this to be the simple and easy to understand for me as a non-obstetrician. So somebody who has got a little bit of abdominal bloating, mild pain, and ovary size on ultrasound is less than 8 centimeter is mild. If you have evidence of ascites along with the mild symptoms and ovary size between 8 and 12 is moderate. And if you have a significant ascites, if you have hydrothorax, if your sodium levels are on the lower end of normal, you have hyperkalemia, your osmolarity may change. In these patients, you would call, and the ovarian size goes above 12 centimeters, you would call them as a severe form of ovarian hyperstimulation syndrome. And the 4 main factors, the 4 main hormones which are sort of responsible for this, and this is what they play upon when they actually want to stimulate the ovaries, is the human gonadotropin hormone and the VGEF, which is the vascular endothelial growth factor, the renin-angiotensin system, and some immune factors. So your pro-inflammatory markers also make a big change in the permeability of the capillaries especially. So what we see in a septic shock, similar kind of a process happens in these patients where there's a leakiness of the capillaries and a lot of third spacing happens. If you look at the symptoms, again, the classification of the Royal Obstetrician College does it quite well. It sort of classifies into mild, moderate. But what really is the severe form which we need to really understand, and if they come in with intractable vomiting, a large ascites, hydrothorax, rapid weight gain, if they gain more than 1 kilo per day for the next couple of days, I think that's a very important sign to sort of differentiate that this patient is going to be in a severe category. And then there's a critical category where you have renal failure, arrhythmias. Remember hyperviscosity, which happens because of loss of fluid from the intravascular compartment, leads to thromboembolic phenomena. And I fortunately, touch wood, not had a patient who had a thromboembolic phenomena, but both venous and arterial thrombosis have been significantly reported in the literature for these patients. So what are the key issues? The key issues is the increased capillary permeability, abdominal pain and nausea, which is very, very bad and intractable, large amount of third space loss, which leads to then hypovolemia and hypotension. And your renal manifestations are basically because the tubules act in a different way. Your proximal tubules will reabsorb sodium and water, leading to oliguria, whereas your distal tubules, there is an impairment of the sodium, potassium, hydrogen channels, the exchange which happens there, and that leads to hyperkalemia and acidosis. And you obviously then land up with a decrease in the urine output, ultimately leading to acute renal failure, oliguria, perhaps anuria, and then you fall into that circle where to try and get out of one, you have to sort of support the kidneys. If you support the kidneys, your viscosity is going to create more problems. So you actually land into a very, very, very painful situation. As I said, hypercoagulable state, you need to think about hemoconcentration and increase in ovarian size because of the steroid use as well at times. Plus, there is a change in the renal perfusion, and because of which the antithrombotic factors go down and the thrombosis is actually promoted. On top of that, if they get it while they have got pregnant, you will see that pregnancy itself is a prothrombotic disease. Though it's a normal physiology, it actually causes a prothrombotic situation in the body. This leads to the significant amount of venous complications, DVTs, pulmonary embolism. We are very, very unfortunate in Indian subcontinent that we have a large amount of CVTs as well, central venous thrombosis as well, which get reported in these patients. And sometimes you may have arterial thrombosis. Thankfully, the number is small, but yes, it's reported. Now, what's the management? How do you manage it? For mild patients, usually it will resolve with home care. In around 7 to 14 days' time, the lady would be completely asymptomatic. You would not have a problem. They just need oral hydration, significant rest, not a lot of simulation there to be done. But at the same time, you can't keep them confined to the bed, otherwise the prothrombotic state creates its own problems. So movement within the house is fine. Analgesics to look after pain, usually paracetamol is enough, antiemetics and daily weight monitoring. For the moderate and severe type, they may benefit from hospitalization. The moderate would probably benefit from hospitalization in the wards, and the severe one would probably benefit from hospitalization in the ICU for a closer fluid management, nothing else. If you can do that in the wards as well, that's fine. You don't need to actually get them into the ICU unless they reach to a critical level where you need to monitor CVP or arterial blood pressure invasively, then that's a different thing. So usually I monitor hematocrit. If the hematocrit is not rising rapidly, it's below 45, I believe it is okay to have that. That's not creating a problem. Pain relief needs to be adequately taken care of. If there is no pregnancy, feel free to use a little bit of opioids. Fentanyl seems to be a perfectly fine medication along with a regular dose of paracetamol, but look at the liver enzymes as well. You don't want to give 4 grams of paracetamol in a patient as an adjuvant analgesia, and the liver enzymes are already starting to creep up. IV fluids. Now this is a very contentious thing. I have around 2 minutes remaining and I'll finish this in a minute's time or so. If you look at IV fluids, colloids were traditionally described. Now, there is overwhelming evidence in critical care that hydroxyethyl starch is an absolute no in these patients, not only these patients, in any critically ill patient. And gelofuscin and gelatins also have something which we do not practice now. So what we use generally is crystalloids. But you give crystalloids to these patients, it will just leak straight away out into the system. So albumin-based fluid, either you use a 20% albumin, 100 mils, dilute it in 500 mils of saline and give it, or you just use the 5% albumin solution which is available, trying to resuscitate these patients, keep the intravascular volume intact. Small allocates of crystalloids can be given, and a DVT prophylaxis is must. My practice is to use unfractionated heparin in these patients. It's the safest one to give, but if you are fond of low molecular weight heparin, look at the creatinine, and then you can use either enoxaparin or you can use dalteparin, which is Fragmin or Clexane or Fragmin, whatever you want to use. Those are the brand names which are there. Also, if they are in the hospital and they are going to be confined to the bed, always use a calf compression device that will act as a secondary prophylaxis for your deep vein thrombosis, and your management will be more smooth. Monitor their liver functions, renal functions, daily CBC. Patients who are critical may require a CVC. Use good volume replacement. Now there is a place for draining hydrothorax and paracentesis if it becomes very difficult for the patient to breathe, or if it is causing a splinting of the diaphragm and you have large volume of ascites which is accumulated. But be very, very cautious. Do not do large volume paracentesis as you would do in a liver failure patient. Take out a liter of fluid, a liter and a half of fluid, replace it with albumin containing fluid, and keep that balance. Remember, in a few days' time, it will settle down. In the literature, they talk about giving some medicines to reverse these changes. Trust me, none of these medicines actually make a difference. So I would like to summarize. Pregnancy is like a stress test, ladies and gentlemen. Please do not take it lightly. If a patient presents to you or a colleague refers to you a patient who is pregnant and who's got some new manifestations of medical problem which were not known before, keep an open eye. And we see one patient every week at least in the ICU with various problems. Ovarian hyperstimulation syndrome thankfully does not come to us in ICU that often. You may be lucky to see 1 or 2 every year maximum, and let's keep it that way. You need to have an early recognition of OHSS as well as all pregnancy related problems, and you need to manage it aggressively. And if most problems can be anticipated, if you keep antenna open, antenna wide there, you will be able to deal with it in a much better way. Thank you very much, and thanks for the kind invitation.